Hi, so today we have Dr. Rachna Kaveri with us. She's the youngest leading gynecologist and obstetrician in Powai. Has been practicing here for about 7 to 10 years. She's done her DNB from Holy Family Hospital in Bandra, post which she further studied in IVF and laparoscopic surgeries, with her interest lying in antenatal care, high-risk pregnancies, laparoscopy, and a little bit of IVF. So I would like to welcome Dr. Rachna.
Thank
Hi,
you so
Rachna.
much. That was a very sweet introduction. Thank you for having me here.
I'm glad. So we do get the patients pregnant, and after they do get pregnant, we have to find an obstetrician who would understand the nuances and the difficulties that an IVF pregnancy faces. Not only medically, but a lot of it is hormone induced or emotional.
Absolutely.
Right?
Yes.
So in your practice, when you get these kind of patients, what are the hormonal effects that you see on these pregnancies?
So I think you've made a lot of cute babies, and I've delivered a lot of them also.
True.
But having said that, IVF pregnancies are a little different from natural pregnancy. We are definitely putting them on hormonal support, and they do require those hormonal support for up until the first trimester. So
Right.
definitely, we cannot deny the role of progesterones and low molecular weight heparins in these pregnancies, because they definitely do help pull us through that first trimester, which is the tricky bit.
Right.
So a lot of my patients would ask me if there's a lot of hormones and injections through the pregnancy, but the essential difference lies in the first trimester, wherein we do have to support the pregnancy, and beyond the first trimester, the pregnancy, of course, along with a little
Right.
bit more care, is as close to a natural pregnancy as possible. So I would say that that's how we try to cater
Right.
to these pregnancies.
So you'd say the first trimester is the one that is a little
most definitely
stronger on the hormones,
Yes,
and then
absolutely.
slowly it kind of weans off.
Correct.
Would you say the hormonal support in a twin pregnancy would be a little more, and they would need to continue that a little more into the second trimester, so they need to be a little more careful?
Yeah. So frankly, we all know that even in a natural twin pregnancy, there are women who come with spotting and subchorionic hemorrhages, for which we do have to put them on progesterone support.
Right.
The issue is that the body does produce progesterone, but in some pregnancies, that luteal support is just not enough.
Right.
In IVF, over and above a twin or a multi-pregnancy, we are dealing with women who have already inherent PCOD, or they might have recurrent miscarriages, which is why we would have to support them through the pregnancy. And yes, based on that, we do customize a care for that patient based on whether it's a twin pregnancy or whether she's had a history of recurrent miscarriages.
Right.
Then yes, we
Yes,
would have
definitely. Or even multiple IVF cycle failures,
Yes.
or high age group, you would be a little more careful in
Careful,
these
absolutely,
pregnancies.
yeah.
Now, when we are talking of high risk pregnancies and high age, do you see a lot of miscarriages in IVF, or do IVF pregnancies have a higher chance of miscarriages?
Yes. Funnily, this is, I think, the first question that any patient would ask
Absolutely.
me, because there's so much information and misinformation online about IVF pregnancies, on whether or not these babies are normal, whether there's a higher miscarriage rate. Because obviously, for an IVF pregnancy, the patient is going through a lot. She is physically, emotionally, mentally, financially very deeply invested in this pregnancy, which is why they want to be 100% sure. And I always tell them that no matter how hard a doctor would try, they cannot guarantee, because this is, I mean, they do really work hard, but eventually it depends on the body to take up that pregnancy, and then
Right.
for how the pregnancy goes. Now, obviously, in that context, I would say that the inherent underlying cause for which the patient had to go in for an IVF,
Right.
like a PCOD or recurrent miscarriages or a thin endometrium, so to say, would be the reason for a miscarriage, if at all
Right.
there is. IVF per se will not increase the risk of miscarriage, but yes, there are also women who have advanced maternal age,
Right.
which is known to cause miscarriages, which is why when you look up the statistics, the miscarriage rate is high, but I don't think IVF per se would cause a higher miscarriage.
right.
In fact, I would say that in IVF, we take such good care, and we're following them up
So true.
frequently. We're doing multiple scans, we are putting them on progesterone support. I do believe that those pregnancies go on to have a better success rate, if at all, so to say.
That is very true, because a lot of IVF patients, by the time they reach us, they have reached the higher age group.
Absolutely.
You know, accepting IVF is still not the first choice for any patient. They would
True.
want to try naturally, and then they reach the higher age group, where automatically the risks increase.
Yeah, absolutely.
So
Yes.
miscarriage is one of the risks that we see at this high age group. What are the other risks that you would be aware of and that you would counsel the patient for in a high age group patient?
So typically IVF and advanced maternal age in general increases the risk of both hypertension, pregnancy-induced hypertension, and to a certain extent diabetes.
Right.
This has also again got to do with underlying cause of the fertility. If the patient is already on a higher side of her
Right.
weight, an obese patient, then that would also further amplify that effect in the patient. But yes, pregnancy-induced hypertension definitely is one of the slight increase, of course, but known causes, side effects of probably a frozen section or a patient with PCOD and then going in for an IVF.
Right. So when we do have these complications, diabetes or pregnancy-induced hypertension, what are the effects that you see on the baby in such condition, and what are the precautions that you would ask the parents to take from the beginning?
Yeah.
They're preparing for it, they're already in the high age group.
Yes.
So how do they prepare for this and try and minimize the risks of these complications?
Yeah. So generally when a patient would come to me for a pre-pregnancy counseling, or we've had a few sessions of ovulation induction
Right.
and they have failed, and we eventually do think that she might require an IVF, I definitely send the patient to optimize her body before she even lands up at an IVF clinic.
Right.
So taking care of her exercise, her weight, her diet definitely makes a whole lot of a difference, not only for the outcome of the pregnancy, but in the beginning, even the outcome of the IVF and the success rate.
Right.
So I think we typically tell patients not to start any new exercise in pregnancy, which is why the body should already be used to these exercises.
Right.
So if a woman is already eating well, eating good whole healthy food, doing a good amount of cardio exercise, then that would definitely set her up for a better start.
Right.
Of course, we put her on prenatal, folic acid and all those things. Another thing that I do tell in the first trimester is, I think each consultation, I speak to them about sugar and salt. I'm
Right.
always behind them, telling them about how sugar can probably increase the chances of going into GDM, because as you know, at 28 weeks that switch happens. So mostly everything is fine up until 28
so
weeks,
true.
and suddenly we do an OGTT and the patient comes up with high sugars, and she's surprised, but we are not so much, because
True.
we know that the load on the liver and overall the pregnancy and heart is definitely increased at 28 weeks, which is why if the patient starts with a low salt diet, keeps her cravings, so to say, at the minimal, or at least doesn't have sugar often or throughout the pregnancy,
Right.
she definitely reduces her risk of developing GDM or PIH in that case.
Great, thank you. That was,
Yeah.
I think, will be very helpful, because in today's world, sugar, I think, is the most harmful substance,
true.
and getting off sugar in any form, whether it's sweets, whether it's sugar, and very often it's like, oh, I don't have sugar, I have brown sugar, I don't have brown sugar, I have
Yes.
good.
Yes.
So
Tell me about
understanding that all these are in the sugar group
Yeah.
and should be avoided.
Another one very tricky, probably controversial thing is fruit juices.
Right.
So I have patients and their family, and really caring family, especially
Right.
IVF. I think the consultation room is full of all the relatives
Total.
taking
It's
care
a
of that
family
woman.
consultation.
Absolutely.
Yeah.
So I have a lot of mothers and mother-in-laws saying that we give her a orange juice every day,
Right.
and she's taking the mosambi and pineapple, whatever it is
Right.
that she's taking. And I always tell them that a healthy, normal young woman would never eat 6 oranges together.
Right.
So if she's only having juices and increasing her sugar and
Absolutely.
fructose, even that can contribute. So probably having a whole fruit rather than having fruit juices is something
Right.
that they should, and that's something which is underlined, and they're not really aware that that could probably lead into
Right.
a situation where she would increase her risk for diabetes.
Yeah, so true.
Yeah.
Now, the other thing is exercise,
Yeah.
right? So, often in the IVF pregnancy, we tell them to take it light. The first few months, we ask them to be basically on house arrest in the early days till the pregnancy test is done, so that we're not exposing them to our Bombay roads and traffic and everything. But once they're positive, then we hand them over to the obstetrician. What kind of exercise would you recommend them to do or not do?
Right. So like I said earlier, I typically tell them not to start anything new, especially in the first trimester, because there's a lot going on in the pregnancy. A lot of development is happening. We are giving them injections and medicines for luteal support. The pregnancy is growing, and as you know, in the first trimester, the pregnancy is entirely dependent on the mother's hormonal melau to sort of pull it through towards the second trimester. Once in the second trimester, the pregnancy and the placenta takes over, and the pregnancy is far more independent, so to say, compared to the first trimester. So definitely first trimester we treat them like a small flower, and then once they are into their second trimester, they can start doing exercises. But yeah, we have a lot of patients who have been doing a good amount of exercise and they just don't stop, which is also okay if your body is used to it. So obviously it's customized based on what patient is already been doing and what is her sort of overall fitness status in that case. But once in the second trimester, we do start a little perinatal yoga. We start them on all the exercises which help in pelvic strengthening and widening and all those exercises. What my patients most definitely end up doing is a little bit of cardio or walking morning and evening, preferably in the sun, so that vitamin D also is something that increases for her, and she also sort of be active through the pregnancy, because that will also reduce her chances for having any complications further on.
So true. Now, we have been talking about the high-risk nature of these pregnancies. How often have you seen that you need to do a preterm delivery, or what are the chances of them going into a preterm delivery? And what are the usual reasons why they would be going into a preterm delivery?
So again, I would say that IVF doesn't per se increase the risk of preterm delivery, but the underlying cause of infertility. We have a lot of patients who have twin pregnancies or multi-pregnancies who might, because of the fetal weight, eventually go in for a preterm delivery. Another reason is protein C, protein S deficiencies, in which case we have to be extremely careful, and if we see some Doppler changes, then we have to eventually deliver the baby or take a decision early. But IVF per se, I don't think so will increase the risk, because these patients are on progesterone support, and if at all, I think are far better taken care of because of all the progesterones they have been taking through the pregnancy. So no, probably the only risk would, the only reason why we would do a preterm in most cases is because of a multi-pregnancy.
Okay. Now, of course, we reached preterm delivery, but a little rewind. Again, these are high-risk pregnancies, high age group. What kind of screening are we looking at to rule out certain abnormalities, either genetic or physical? What are the mandatory investigations that you would say? Would they differ from a normal pregnancy? Is there something more you would do in an IVF pregnancy, or it would go the same way?
So IVF pregnancy, because of advanced maternal age, is something that I think requires special attentions. We of course in each and every patient, IVF or otherwise, do the dual marker and the quadruple marker to rule out any chromosomal abnormalities like Downs and Edwards and Pataus. We all know that risk is obviously increased once the maternal age crosses 35. So in IVF, because a lot of, like you mentioned earlier, patients do come much after trying everything else. So we are dealing with women who are 35 and above a lot of times, which is why we definitely make sure we do these tests. Another test that again we do a little frequent scans just to make sure the fetal viability and the fetal well-being of the baby basically is okay. Another thing we do is that we do a couple of scans just to keep checking cervical length, because in twin pregnancies and multi-pregnancies, we want to make sure the cervix is okay. Not all IVF pregnancies require a cervical stitch, which is also one of the things that a lot of patients ask, that if we have twin pregnancies,
is it mandatory to do?
Are we looking at a cervical circlage procedure compulsory? But that's not true. In fact, I think one of the patients we've done an IUI and here has a twin gestation, and we've not put a stitch. She's doing great. The cervical length is good. So we are just observing, watching, probably doing scans slightly more frequently than a normal pregnancy, but that's about it. So coming back to what investigations, I would say, and yes, now a lot of patients are themselves coming up and asking for an NIPT. So that trend is also changing. The awareness is increasing, obviously. So instead of going for a dual marker, a lot of people do prefer to directly go for an NIPT. And I think it's absolutely okay if a patient would demand that, because that would definitely make it more that should be at peace of mind, and that's absolutely
earlier test, much earlier that this was fine.
Yes.
The next would be, now we've done the screening, we've done the preterm. At birth, what are the chances of a IVF pregnancy needing a cesarean section? Is there a higher chance? Is there a voluntary cesarean option? How do you decide whether you need a cesarean or not?
Yeah. Funnily, this is the first question the patient asks once her UPT is positive.
Right.
They're very tensed about whether or not they get pregnant. They go to multiple centers, then they eventually end up here.
Right.
They get pregnant and they get a positive UPT report. They come back to me and the first question is, "Okay, doctor, kya mera normal delivery hoga ya cesarean?" And I tell them to just breathe. I'm like, you just got pregnant. You've got 9 months to figure it out. Wait, we'll see. So as you know that guidelines don't, there's no guidelines saying do a cesarean section for a patient who's gotten pregnant through IVF. But I have to be honest here. A lot of times the patient themselves will opt for an elective cesarean section because they've been through a lot, right? They've been through a lot mentally, physically. They've gone through all these hormonal cycles, and after the the outcome has come to be a positive pregnancy test, and they after that just don't want to take a chance, and they want to have a good, nice, elective date for a cesarean, and they want to go through that process.
Right.
But we do have patients who want a trial for labor, and by all means we give a trial for labor for these patients.
Right.
Our threshold to go in for an early emergency cesarean would be slightly higher in these patients, not because we are anticipating any problem, but because we just want to make sure that the baby comes out crying.
Right.
So we would put them on continuous monitoring, and we could induce them and give a good trial for labor. But if we see any warning signs, so to say, then we definitely counsel them for early cesarean versus a slightly higher threshold for somebody who's gotten pregnant.
So a shorter trial of labor, and then you take them up for a C-section. That's great. So we were talking about the investigations that we do to rule out certain genetic disorders or anomalies. So one of the major questions that patients would ask is, are the babies born through IVF normal?
Yeah.
Do you get that question often?
All the time. So there's a lot of skepticism around IVF, and it's always a hush-hush topic, and I think a lot of times patients are not even comfortable disclosing that it's an IVF pregnancy. So it's, so to say, a taboo to even let relatives knowing about it. So which is why there's a lot of misinformation, and a lot of patients do want to know if the babies are going to come out looking normal, are genetically normal, are mentally normal as well. I mean, if they're doing well in all walks of their life overall. But there's no difference, as you know, in an IVF baby or a baby who's conceived naturally.
So true.
They're genetically perfectly normal. Chromosomally, everything is okay, because we also do
You've
all
already
these
done
tests.
the tests.
Yeah,
that's right.
So they are very well investigated. They're absolutely normal. There's no increased risk of physical deformities in these babies, or no increased risk of chromosomal issues, so to say. Of course, advanced maternal age leading to an IVF pregnancy does have an increased rate. But eventually, having said that, since we're anyway doing the test and we rule out everything and only then let the pregnancy continue, I don't think it interferes in the percentage of how many genetically normal babies are born. I think it's more or less the same.
Okay. The other thing is, other than genetic disorders, there are developmental disorders.
Yeah.
Is that higher in IVF?
So, no, IVF per se would not cause an increased risk of developmental disorders like ADHDs and autism and multiple other things. Certain medicines that the patients take does increase the risk. But we do take care in the sense of putting these patients on higher folic acids and putting in choline in their folic acid, and that sort of helps us to navigate that situation in a better way. So, eventually these patients do really well.
Right. So like you said, you put them on certain medications to help with these. Are there some medications that would go throughout the 9 months? Because the first 3 months are quite intensive with all the IVF medications they're taking. What about the rest of the pregnancy? Are they heavy on medications, or are there's some medications that you can drop, some medications that have to continue? How do you look at that?
So first 3 months, they're definitely taking more hormones, they're taking some injections and all of those. But once after the 12 weeks, we switch up the whole routine, and more or less they're taking the same medicines that a natural pregnant patient would take, like their irons and calciums and all those.
Right.
We do put them on progesterone support for longer, and sometimes in some cases we put them through 36 weeks of progesterone support.
Right.
Because just to be additionally careful, and for whatever luteal phase defect that they can come up with in the later weeks of the pregnancy, we would put them on progesterone. Another thing that I think we generally do is putting them up on low molecular weight heparin.
So true.
Not only does it improve our outcome for delivery, but also reduces the chances of hypertension in these patients, which we are anticipating to a certain extent.
Yes.
So to have a very smooth pregnancy for them, these patients are on low molecular weight heparins, but usually these patients are okay with it because the needle size is okay, and mostly the hassle is that they have to sometimes come to the hospitals to take, or the clinics.
Right.
But low molecular weight is something that the patient herself takes, so they don't really find it too bothersome.
So their visit to the hospitals are minimized.
Yes.
So what we have basically seen that a lot of misinterpretation, information that is not adequate, and certain myths that are kind of getting the patients worried about an IVF treatment.
Yeah.
So let's address some of the myths that we have here. What would we say about traveling in IVF?
First three months avoid. Then with due risk you could travel.
Okay.
I think you would also have a lot of patients coming in for medical tourism who would come to your
Absolutely.
centers from different continents, get an IVF cycle, get pregnant, and then travel back in the
Sometimes they travel back after the embryo transfer.
Oh.
And they'll rest here for maybe 5 days or 10 days, and then they go back and carry most of the medications from here.
Yeah.
Have a doctor there who's standby
Correct.
for the rest of the thing, and they do pretty well.
Yeah.
My main fear is only in Mumbai, where we are looking at travel time to work being horrendous, traffic being even worse, road conditions being what they are. So in such conditions, in the first month at least, I am like minimum travel.
Yeah.
And now with the advent of work from home, things are much easier. So I think.
But yeah, most of my patients are definitely going for a baby moon in the second trimester. So they're having a lot of fun, and they're taking it easy because they've had a tough time before this. And they've been through a lot of injections and hormones and scans and all of that. So they definitely need to take it easy.
Yeah.
So I would say second trimester onwards, there's not any travel restriction, so to say.
Great. Yeah, that's the time they have to enjoy their pregnancy.
Absolutely, yeah.
IVF pregnancies are always a high risk.
Not really. I mean, depends if you are already of an advanced, if you're dealing with somebody who has an advanced maternal age, previous miscarriages, twin pregnancy, multi-pregnancy, then yes, to a certain extent. But other than that, no. Most of the patients are doing everything normally up from the second trimester onwards.
Miscarriages are more common in IVF pregnancies.
I think we already spoke about it. Miscarriages not because of IVF, but because of situations leading to an IVF pregnancy.
Great. So this was wonderful. Yeah, we've covered almost everything that a woman would go from conception to delivery in an IVF pregnancy.
Yes.
So what is that one take-home message that you would like to give these IVF pregnancies?
I'll say, so IVF pregnancies are made with a lot of love and hard work and a little bit of science. How the pregnancy grows in the womb is the same, and how the mother carries her pregnancy in the womb and beyond remains absolutely the same.
So they should not really be worried.
Not
and
at all.
should not be scared of going.
I hope they feel like they are in good hands when they come to us. So I hope that also
that I
helps
agree
them.
with. Yes. So they should not be too scared and not delay their start in the journey just because they're scared of going in for IVF.
True.
Lovely having you with us.
Thank you. It was a pleasure. It was a lot of fun. Sunday morning.
Yes, absolutely. And a lot of information for all our patients. So I'm glad you could make it. Thank you.
Thank you.